going to invite all of the speakers to come up. This is the part of the symposium where we get to invite the speakers to come up and for you in the audience to participate. I just want to remind you for the folks online of the two ways in which you can you can submit your question, either through an email, events@amsa.org, or you could tweet questions to #AMSA-events or @AMSA-BC. Trish, if you could give a little wave here in the audience, we'll be having a microphone, and so if you're wanting to speak from here on site, please raise your hand and she'll bring the microphone to you. We request that you ask your questions into the microphone so our folks online can actually hear what you're asking. Before we start, sorry, just want to, we will have somebody, sorry, Katie, will be reading out the questions online and from the Twitter, and we will rotate back and forth from on the site here and the online. I think there's got to be a bazillion questions because I know I've got tons, and each of these presentations have brought up sort of myriad of different issues, and as I said earlier, highlight the complexities that we're working with. I think the title of the symposium, Collaboration Approaches to Promoting Newcomer Health, is very, very relevant and highly important. I think not just collaborating across the sectors, although that we can talk about that between settlement and health, but also within the health sector ourselves as somebody from health. The PHSA Health Authority, and we've got Coastal and we've got Fraser here. I mean, it just goes to show us that we are in some ways geographically restricted in terms of the services that we're providing. It doesn't mean that we can't have these conversations across those geographic regions, especially given that we know that newcomers, particularly newcomers, are still very much migrants. So when they come to Canada and housing is an issue, we can't expect them to stay within one health authority. So those relationships that we're building across the health authorities are even more important in enhancing our relationships with settlement services who aren't constricted to those geographic regions as we are. So an organization like AMSA, which is representative of settlement services across the province, that's really important for us to be making those connections and to be having that ongoing dialogue. So appreciate AMSA for bringing us all together today. So I open up the floor to questions. Do we have any questions?
Thank you. Does this work? Yeah. Thank you to all the three presenters. It was a really nice presentation and informative and and very relevant to me because I am a newcomer, just have been here over the past 4 months. So my question is open to all of the three presenters. Like all of you have pointed out that communication is the key point that you have found in your research. So what has been done, like I'll just give you one situation that I have recently faced. The one important point is that information actually is lacking. That is what I found. Even though I have a good background of health education, for me to find these relevant information is really difficult as from a provider, the people who is using the health system. So for despite that, it is difficult. And another thing is like we have got the MSP health card, and despite having that, a few weeks ago, we have to use that card. And when we went there to use it from the clinic, they said it's not working. So as you've said, Dr. Mailing, that it can be back billed, but despite having that card, they said it's not working, and then we didn't know that, and then we have to pay upfront, because if we don't pay it, then we don't get the service. So there are a lot of issues going on. I mean, that's my personal experience that I found. So what do you have to say, like how it will work and what can be done in the future to help these kind of problem to be resolved? Thank you.
So, yeah, that's a perfect example. You are so not alone in that experience. And, you know, I think that is where really continuing to have this conversation between ourselves in the health sectors and the settlement agency and newcomers themselves to make sure that everybody understands their rights, because so many people, there's confusion at a number of different levels. And what can happen in practice is exactly that, where we kind of hold this knowledge here, but on the ground, you are experiencing a barrier, and there's this big disconnect. You know, we're here and we are the people that should be informing the rest of the health sector, but for whatever reason, the health sector isn't getting that message. So for me, it's important that both us in the health sector do as many, you know, sort of presentations and workshops and, you know, editorials, any number of things to try and educate our own peers, but also that we really work with settlement and with newcomers to help them understand their rights on the ground, so that the next time you go to a provider and they tell you your MSP card isn't working, you can say, well, did you know you could hold this number for 90 days and then back bill it? You can wait until it's activated, but also that this not being activated should not be a barrier to a service. Like, you shouldn't, whether or not you access healthcare in Canada should not be decided on your ability to pay. Right? This is a basic right.
That's what I believed, but I was so surprised that they were, adamant that you should pay or else you won't get the service, because we are at the verge of in an emergency situation, so we can't think about the money thing at that moment. So,
I know, and
so I was quite surprised. Oh my God!
I know, and that's where our efforts around education need to be amplified. Greatly.
So and at that time, not only us as who is taking the service, the providers and the access to information should be like, where does the newcomer goes first? Like you have already pointed out, the service sectors, the settlement services, and everywhere. So the health system should be, I think, quite related to all those areas where the point of contact, the newcomer should be there, so that, and until and unless, it's not that it should be a mandatory that they should get the information before asking. Like, I have my own experience that I went to some health settlement services, but nobody talked about the health service system. So they should not wait until we ask them, but it should be given as a mandatory information, like where you go to get a service for language, or where you get a survival job or something like that, or where you get housing services, like that. Health information should be also given as a mandatory. Thank you.
Yeah, thank you.
Did any of the other panelists want to comment on that? Naomi?
No, that was great, I think. Are our mics on?
Yeah.
Okay. I just wanted to comment that I also think that this forum has emphasized a point that is about the work we do together as health authorities and our complicated inability to collaborate. And I kept thinking this morning, I wish I worked with these people directly all the time. So that's my number one takeaway from this. But it's also a point that I think others have made, which is about how we are working together between sectors. The project that we undertook at Women's only happened because a new policy advisor within the Ministry of Health had come from the Ministry of Jobs, Tourism and Skills Training. So she was aware of the unique situation that was going on in terms of the funding transition and the opportunities, and she had her personal capacity to bridge that relationship. It all rested on her. And she was able to leverage that conversation. So when I start talking, it sounds bureaucratic, and no, it was the leadership and initiative of a single individual who in turn was able to mobilize all these fantastic resources. So her unique knowledge was the bridge. So I think there's also efforts that we need to make to support one another. And I've heard through our process that the health is not always the first priority when people come to Canada, because there are many, many things to deal with. So unless it's an emergency, it gets kind of put aside. A question I have back to the settlement sector is what's the status of the health pages in the Newcomer guide that was available? Are they up to date? Are they currently accurate? I assume that they're going to be inaccurate as of April 1st, but that was, again, one document that combined a number of pieces of information, including the health pages, that I did think was of some value, but I do think that this whole conversation calls for more conversation between our sectors. Thank you.
Does somebody from settlement want to respond to Anne's question? Or that's something maybe we can ponder. Do we have a question online?
Yeah, we do. We have several questions online, so I'm trying to organize and categorize them for you, so they're coming in groups. So I'd like to pose these first two questions to Anne and Naomi. And we had an E-Symposium recently on cultural safety. Could you talk a bit more about cultural humility, maybe expand on that a little bit? And Naomi, kind of related, could you explain about diversity competency and why Fraser Health selected this wording?
Thank you. It's exciting to have this conversation. We adopted the concept of cultural humility because we saw it as a tool for creating cultural safety. So in other words, it's a process and a stance that providers of any sort or a person will adopt. The goal of cultural humility is the creation of culturally safe experiences, settings, processes. So on that continuum from, I'm going to call it culturally blind, to neutral, to aware and sensitive, to specific, at the far end would be culturally safe. But to get to that, you need a position. And since we specifically were challenging that view of cultural competency as about learning the 5 top things you need to know about any cultural group, but rather moving to a broad notion that what you need to be is open and curious about another person and their experience. That's how we understand the concept of cultural humility. I hope that answers the question.
Sure. And then diversity competency. So there's a few reasons that we use that term, but there's also a few things that other terms really highlight that the term diversity competency doesn't. But when we think about everything that it takes to, for example, in a healthcare setting, to provide good care to all people, we think of what makes up individual people, and the ways that we are different from each other are more than just around kind of what is commonly thought of as culture, right? Which tends to be kind of race, ethnicity, background. There are other ways of thinking about culture, but that's how it's kind of commonly understood in everyday language. But when we think of the ways that we're different and similar as people, we're so much more than that, right? There's age, there's gender, there's our role in society. It's so wide-ranging, the facets that make up who we are. So that's why the term diversity instead of culture. And then the competency piece, as opposed to safety or humility, it is about emphasizing that there are specific skills that one can acquire. And my colleague in diversity services has actually done something to develop what she sees as kind of 12 components of being diversity competent for Fraser Health. And I'm happy to share that with anyone that asks about it. And so in there are things, for example, like what Anne pointed to, the point that it's about lifelong learning. And it is about humility. It's not just about do this and this and this and then you're done.
Yeah.
So I'm happy to share more on those resources.
Good, thank you. I had a comment and a question, and this goes to the cultural diversity piece, but it also goes back to the previous question around health information and how do we transfer that knowledge around systems. And all three of you actually brought up the notion of cultural brokers. And we've identified these big issues of navigating the health system, of language services, of getting education, and each of you very briefly said, well, we should look at cultural brokers. So I'd like you to comment a little bit on that. You know, what in your mind is a cultural broker, and how is that different than just somebody that helps you navigate the health system?
I can start and we can all jump in as needed. In my mind, a culture booker is absolutely someone who navigates the helps someone to navigate the health system. But there's a couple of special sets of skills. It's someone that has kind of cultural fluency, we might say, or cultural skills and understanding, both in the culture of the patient or the client who is the immigrant or migrant person, as well as that of the culture, not only here in Canada, but specifically what kind of the healthcare culture is in Canada. So how do doctors and nurses tend to see issues, and how are services set up? So they can bring both of those pieces together and help not only the patient to navigate the system, but also help the provider to understand the patient's worldview and the patient's understanding of health. So to kind of bring mutual understanding to that situation. Often the cross-cultural health workers that I've worked with have a background in healthcare as well, so they have some kind of biomedical knowledge of health and illness in the way that the patient will understand it, as well as the way that the Canadian provider will understand it, and that can be really helpful.
Yeah, I have nothing to add to that. That was exactly it. I just think of it in my head as a role, not just of navigation, but of like mediation, kind of negotiation and advocacy, all of those pieces rolled in together. Because I think those are all pieces that we've heard are lacking or necessary, and I think you can actually roll that into sort of a single role for a person or group of people.
And if I could add in, our hospital, we have a system of Indigenous patient liaisons, and that indeed is their role. It is bridging the two systems, but also advocacy on behalf of the patients, and I think that's a critical point you make.
Yeah. Absolutely, and just to build on that maybe, one of the kind of debates that we've been having internally when looking at what might this look like to start up a cross-cultural health broker program maybe for Fraser Health is around if part of their role is to do advocacy, then does it make sense that they are employees or volunteers of the health authority or of the hospital, or do they really need to be external to that organization to be able to do a proper role of advocacy and really be the support for the patient, or is that not necessarily the most important piece? As well as practically, when you're looking at a region like Fraser Health in Surrey or in Burnaby, for example, and you've got this super diversity, like what does it look like to have a program where realistically you have support for patients from every kind of cultural background and context? How is that feasible, and what can that look like?
And I think that's where we need to take our lessons again, we meaning health, need to take our lessons from settlement. So the variety of reasons why newcomers come to Canada and the myriad of manners in which they do that. So whether they're, landed immigrants, or they come as citizens, or they come as refugees, or they come as migrant workers. For the number of reasons why people get here and how they get here, there are that many perceptions of health and health-seeking behavior. So what does health actually mean to somebody that comes from Eritrea or Somalia or Thailand, and how is that different from how we perceive health in Canada, and what are our expectations in terms of health-seeking behavior and uptake in health services? Therefore, the expertise of the settlement worker is highly important. And I would add to, I like your definition of cultural brokers, I would add to that, it's also about building social networks, because we see a lot of newcomers coming here that may not be coming sponsored by a religious organization or a cultural group, but they're coming individually as families or just on their own, and they lack that social network, and they tend to start their life in Canada in isolation. And how is one then supposed to know and to learn about what is available to them if they don't have contact with like persons? Again, as Canadians, we make assumptions about what people think they want or what they think they need.
Yeah.
So it's something for the audience to think about as well. Do you have any other questions? Online, is there another question?
Yep, I have quite a few online. I just want to make sure nobody in-house wanted to ask one first. And so I've got two questions that have come in for you, so I'm going to group them together. The first is that you mentioned that your recommendations were somewhat guided by the time-bound nature of the project. What are some of the longer-term actions that might need to be taken? And the second piece is, what is the evaluation process for your project?
Great questions. I'm practicing for my thesis defense. It's quite true, that was a time-limited project, and the biggest loss of that, of course, would be personnel. And not mandate, but personnel, just the on-the-ground, day-to-day help to do the work. And so we are looking for funding, which of course supplies both resources to reprint those materials in other languages, as well as staffing. We don't have a position analogous to the Fraser Health Diversity Services, and that's a challenge. PHSA is complicated in the sense of its structures, and again, our work wasn't only for PHSA, but just to say that because I sit inside that world, I'm expected to also support and interact with it. So the longer term things that we were not able to instigate include the kind of education that we're talking about, systemic structural changes, the creation. When I start, you can tell from the things I've said that I've been around a while, when I started at BC Women's in 1996, we had diversity officers. Those people worked on equity for LGBTQ populations, they worked across language services, they worked in a whole range of issues. All of those positions were lost. We are continuing 2 decades later to do that work, 3 decades later, to do that work in another, like recreate, because the need never went away. So I think we're talking about recreating positions, capacities, hopefully as the population of newcomers comes to live in Canada and be educated here, they will become part of these various systems and help transform them from within, etc. So many, many things to do, and our work is far from done. With respect strictly to the cultural connected.ca evaluation, we're looking to do user testing. When it was built, we actually want to see how people navigate and use it, so we want some people who are healthcare providers to come and tell us about how it works. There will be a survey with questions and so on that's just going through a privacy review right now, so it's not accessible yet, but super happy to put the word out there. We will be, this is phase 1, so it'll be really about the content as it exists right now, and we'll ask questions about what other topics people would see as valuable, whether the tools are understandable and interpretable. So it's both about the content and about the usability of the tool in its format. As I said, it was built to be mobile friendly. It was built to use on a phone. To our surprise, there are all kinds of situations in which healthcare providers cannot use phones, and so they have to actually use other devices in which to use it. So we need feedback on all of those mechanisms. One of the reasons we chose an online format, despite everything you've heard, is because of its flexibility, but also, to circle back to where I started, because we have no infrastructure to keep this thing alive. I don't have a department of diversity services to continue to do and maintain online any form of training. So an online resource was one way with the limited resources that came from, it was inspired by the first project. We found funds from the population health community at the Health Authority. They're all one-off attempts to try to piece together some kind of meaningful complementary set of resources. But we need to, before we go forward, we need to stop, pause, evaluate what we're doing, and get feedback. So I look forward to anyone who wants to know more about it, about getting in touch with us.
Thank you. There's a question in the back.
Oh, sorry, yeah. My name is Lam, and I'm also a settlement worker. So my question goes to, I think, all of you. That is, I work with newcomer immigrants. And one of the issues that usually come up is that many of them don't have family doctors at all. And that's a big struggle. And I know one of the problem might be a language barrier, because many of them are thinking that, like, why can't we have doctors speaking multiple languages? That would make life easier for most of us. But I just want to know, how much efforts, are you making in ensuring that newcomer immigrants have easy access to family doctors as well?
Yeah. This is a huge struggle for us and probably one of our primary priorities. But I will note that it's a huge struggle for many people. So, this is where we run into some of those competing priorities when we're trying to advocate for measures that would make it easier for family doctors to take on newcomer patients. We run into other people who are saying, but what about my complex elderly patient? And what about my, complex developmentally disabled child who needs a family doctor? So there's a lot of competing priorities and, not enough family doctors. So there's a number of fronts on which I think we can work on this. So one of them is continuing education. So we are working with UBC CPD, which is continuing professional development, which develops content for physicians that all physicians are required to do sort of ongoing training and get education credits. So what we can do is develop workshops around newcomer health and taking newcomers into your practice that can be part of that continuing education, so that any doctor who's interested could come and learn some very practical things about taking newcomers into your practice. Is there any special billing code? How do you access translation services? Are there any differences about newcomer health that might be pertinent to ongoing care? But generally, we want to go spread the message that it's actually the same. It's part of the broad spectrum of family medicine to have newcomers in your practice. This is just, part of the usual diversity of the human condition. So we're out there trying to encourage people to take people into their practice. Another thing that we're hoping to do is partner with some of the programs that train international medical graduates. So these are graduates that come here from other places, many of them speaking languages that are pertinent to the populations that we see, and then try and find a way for them, if they have to do a return of service in the Fraser region, to see if we can be part of their training so that they can take on people and speak the same language, which is huge. It's so nice to have a language concordant provider. And then, we just try to get the word out there. So we spend a lot of time on the phone, encouraging our friends, talking to other people just informally to encourage them to take on newcomer patients. But it's a challenge. Everybody's strapped. I feel your pain. We feel it too.
I just wanted to add that I think finding a family physician is a challenge for Canadians, not just for newcomers. I think it's a systemic problem that we have, and it's part of one of, I think, the things the health, our ministry needs to sort of reflect on, and it's the system by which we have it. Not that I want to put anybody on the spot, but I'm looking at my colleague in the audience, that as just a reminder that nurse practitioners are as capable and do the same job that family physicians do. And so I think, again, this is about us providing education to communities. I'll give you 2 secs. To communities that these professionals are available and they're not as known as they should be. So I want to invite Tamara Stillwell to say a couple of words. She is a nurse practitioner with BC Women's.
Thank you. I just wanted to comment that, yes, nurse practitioners are very capable of providing this care and do in many of the settings in Fraser Health and also at Bridge Clinic, as you know. But we are quite limited by having to be hired by health authorities and the limited funding. So one of the pieces that we all need to advocate for is the funding mechanisms by which we can provide the care that we're capable of. There's nurse practitioners available, really excited about providing the care, but limited by the current mechanisms within which we work. So that's one way that we can all get more access to primary care, newcomers and other people living here is by advocating for more nurse practitioners in the system. Just to plug our profession a little bit here. Thank you.
Great. Thanks so much, Tamara.
Can I make a comment?
Sure.
I also wanted to revisit the conversation that in your presentation that you made before about the experiments underway in the divisions of family practice for the use of translation services, because that's truly innovative and has the potential to transform primary care. And I know, it had to happen through complex, incentives and billing practices and so on, all of which are the backstory for how healthcare moves at a glacial pace. However, the fact that it has been proven successful, that it does work, that there are mechanisms, is very exciting. Just a caution, of course, that linguistic competency is not always going to be the magic key to a successful patient-provider relationship. And indeed, in some situations, if a community is very small, it might put someone in a position where they felt that they were disclosing information about themselves or a family member that they would prefer to tell a stranger because they don't want it to go back to anyone within their community. And so despite, the bounds of privilege and privacy that we're all bound to, nevertheless, that can be violated. And we certainly hear that with women who often are concerned that people not know their very personal business. So it's both a magic tool and facilitator and occasionally an important constraint. And so what we want is a system and individuals who will avail themselves of the possible ways to have an effective, productive relationship regardless of the circumstances. Although I'm reminded that in 1989 I visited family in Norway, and my cousin's partner was the principal of an elementary school, and given their very progressive language policies and principles of equity, she had to provide educational instruction at that time for 52 language groups. And that was part of everyday life in this small community. So I think as a country, we could go a lot further to promoting and sustaining and supporting linguistic diversity in other ways beyond just the healthcare system.
Great.
Yep.
Tamara has
Yep, do you have another online?
Okay.
Sorry, do you have a follow-up?
Yeah.
Sorry.
Just two very quick add-ons to what Anne just said. Other barriers are within the communities is actual discrimination, where people come from an area where they are a discriminated minority. Particularly, I've experienced this with Vietnamese people, that they don't want to see the higher status Vietnamese doctor because they've been discriminated against by that other cultural group within their country. So we all have to keep that one in mind. And then the other is it's also very important that we advocate for language services for specialties, because that's a huge barrier I'm encountering, is not being able to get people to specialists because there's no interpretation available there either.
Yeah, I'll just add a note to that, is that we very frequently, because we see refugees and people are escaping an oppressive system, very frequently do not want to see someone who's a representative of the oppressive system from which they escaped. This is especially true of people who of like differing sexual identities and our trans clients for sure. And so I agree, like it's important to have a system with like a diverse array of possible care options to, and this is true, I mean, really outside of the newcomer field entirely, I see, English-speaking, Canadian-born clients who have very contentious relations with their family doctors for other reasons, because I do a lot of family planning work, and so, I think that's something that as a system, for sure, we could improve. But yeah, it's gonna be a challenge. Definitely we're in it for the long haul.
And that is a hurdle that we have heard about across the settlement sector as well, is that somebody who is a newcomer from a particular country does not necessarily always want services provided by somebody from that country. And so this is definitely a common theme across all parts of the settlement process. So I'm going to blend a couple of questions again that have come in for Mei Ling. If you could please elaborate on the situation of undocumented migrants living in BC in regards to their status with healthcare. And then the next part of that question was, with changes to interim health, will services be available to undocumented migrants as well as refugee claimants, PSRs and GARs?
So I probably need a little more clarification on just talking generally about undocumented patients. Can you repeat that question, or is there more to it?
No, that's
Okay,
the whole question,
just
but I
elaborate
can,
on undocumented people?
Yeah, so it's more about the situation for health status and access to health care for undocumented migrants.
Yeah.
And then also in light of the changes to interim federal health starting on April 1st.
So this is something that Naomi probably can also address. Access is incredibly challenging for people without documentation. For a variety of reasons. Some of those can be at the level of the person where they may fear, for a number of reasons, trying to access care due to their lack of documentation. And then, this is for good reason, because there have been a number of cases where healthcare providers have inappropriately reported people to CBSA and other agencies in the sort of process of trying to get payment. And so obviously this is inappropriate, but this is again an issue of policy versus gatekeeper. So this is something where the knowledge about what our priorities are and what our legal and ethical responsibilities are at the front line need to be really clear. Because in fact it's preventing people from accessing necessary care. And the fact that, in this country, care is not supposed to be adjudicated based on your ability to pay, should be there for everybody, regardless of your documentation status. But in actual fact, that's variable from location to location. Like, you might even go to the same location at different times and have a different person at the front door and have a totally different experience. And so that's a huge challenge, and one that I think there's incredibly good advocacy groups across the country working on this issue, and so there's a lot of education that needs to be done at the health authority level, at the provincial level, and at the frontline level about what our rights and responsibilities are with regard to people without documentation. And then the second piece is that with the changes in IFH, I don't think that it'll affect people without documentation very much, simply because the insurance is pretty much tied to your status as a refugee. So if you've gotten to a point where all of your refugee process has been exhausted, then the coverage ends. Like, it terminates pretty much as soon as all of the appeals and everything have ended. So I can't imagine that it'll change access very much. But just those changes might be an opportunity for us to increase knowledge a little bit around what our rights and responsibilities are. So that's the unfortunate answer to that question. Anything to add?
Sure, I'll just add to that a little bit. Excuse me. That absolutely, it's a huge problem, and there's not an easy answer. And as many of you might know, because it's been in the media lately, there have been some issues around at Fraser Health on this. So even though the formal policy on paper is that if it's an urgent situation, you provide the care and then ask questions and deal with billing later. In practice, that doesn't always happen. And so when someone is asked up front for payment, but not told, you don't necessarily have to pay, we'll provide you the care anyways.
Yeah.
It doesn't look like that to them. And also that, as Mei Ling mentioned, as you might have seen in the media too, that there have been cases where border services are alerted when there is a patient, either intentionally or unintentionally, when there is a patient who's undocumented in the healthcare system. So just creating huge legitimate fear of accessing services, right?
I will say that both of our health authorities are working on policy around this, and so we're both involved and we'll be sort of pushing for that policy to be communicated effectively and clearly to the frontline staff. But it's a tough issue.
Absolutely. And Caitlin, if you don't mind me saying, my understanding is that the Newcomer Women's Clinic at Children and Women's will see people who are undocumented, and there are a couple of other services here and there that will do the same. So if you're looking for something specific, please do email us and we can try to connect you with the right pieces that are safe and will provide care.
Yeah, I just to add to that, yes, the Newcomer Clinic will see women who are uninsured. That said, there are some ethical conundrums that come up for us in regards to that. So even though our frontline workers have the ability to see those women and are willing to see those women, what comes up for us is what happens to them if they need further testing, if something comes up in that testing and they need to see a specialist. We cannot speak for specialty providers. We cannot speak for technicians that need to do ultrasounds and mammograms and things like that. And so we have this ongoing conversation amongst ourselves about what are the ethics of seeing somebody, where you don't want to deny somebody service, but at the same time, how can we start offering that service if we can't see it through to the end? We haven't come up with an answer for that. We still continue to see women, but it is a conversation that needs to come up when we talk within our health authorities. It's not just putting the frontline workers out there and saying, yeah, we'll see you and we'll do a pap test for you, or we'll do an STI test, or we'll put in an IUD. It's so much more than that. And so we need to look at it beyond that first visit. So, it's challenging, and it's challenging for settlement agencies who are trying to advocate for the newcomers that they represent as well, and we absolutely respect that and want to be there to provide that service. But when we have to say no, we have to say no, and it's because we're wrestling with our own issues as well in terms of what is it that we can provide and what is it that we can't provide, and where is it ethical to start.
I do think that this is where advocacy groups play a huge role in continuing to push us and push our health authorities. This is like where your skating analogy is going to need that little push and that continual pressure to keep the issue present. And yeah.
And to push the conversation to be larger than just that, again, that front line and to that first visit, because that is just the opening of a door that is so much bigger than any of us really understand. Mm-hmm. Are there any other questions?
There's one that I'm hoping we can finish up with, because I know we only have about 2 or 3 minutes left, but I'm really hoping you could weigh in on it for us really quickly. What do you see as the desired partnership model between settlement service providers and the health sector? And I know just a big question, short amount of time, but if you can kind of just sum it up for people watching at home.
You can start. Sure. I mean, in my mind, I don't envision there's a formal model necessarily, but just so much more communication, right? And as I mentioned before, having roles within the health authority that are able to do some of the outreach, that can come to your settlement organizations and be part of presentations and groups that are happening there, and vice versa. We know that a lot of settlement organizations are kind of tied to their offices, and there are some that do an incredible amount of work in accompaniment to health services and to others, but to keep expanding those programs and those roles so that we can not only talk and communicate and share information back and forth, but physically help people go back and forth and have kind of those soft hand-ups and build that trust and avoid anyone slipping through the cracks that happens way too often.
Yeah, I mean, I'd build on that to say that the difficulty of developing a structured model is that this particular group, it fluxes and changes, the needs will always be changing, the size and the population groups that have needs and what they are will always change. And it's really important when you're developing communication models to have a system that is responsive, because you can spend a ton of time doing a ton of work and creating a static model, and then 3 years later it'll basically be obsolete and not helpful or doesn't apply anymore because groups have changed and moved on. And so I agree, having something both formal and informal where, we meet and we share, but also some formal resources where, we can kind of pass back and forth information are going to be crucial going forward. Just continuing to have these kinds of, AMSA, umbrella type conversations are always going to be useful.
I couldn't agree better or more. But also to say, as per your slide about the determinants of health, let's not forget that there are a lot of other influences on health. And so while we are the formal health sector, there is a whole other set of groups of people who are going to help us all enhance the health of newcomers through their efforts as well. So the dialogue is actually multi-sectoral, not just bisectoral. And that's not to make it more challenging, but to make it more inviting and inclusive. Thank you.
Thank you. And I think, yeah, just further to that, it's not just multi-sectoral, we're talking about different levels of government, both provincial and federal and even local. So it's so much more complex than that, and I can't keep saying the word complex enough when we talk about these issues, but it has given us food for thought. This has been an amazing forum. I think it is a really good mechanism for bringing sectors together, bringing intersectoral and intergovernmental organizations together. So I'm going to leave you with that. Hopefully we'll have opportunity in the future to get together and talk about this some more, because I do think it's highly relevant and extremely important. I want to acknowledge again Immigration, Refugee and Citizenship Canada for providing the funding for this event. Also, I'd like to thank the great work of our audiovisual team, the three fellows here, from XE Live Broadcast, who are bringing the event to the online audiences, allows us to reach so many more people across all the corners of the province, and that is really important to our colleagues who don't have the advantage of being in a hub such as Vancouver or Surrey. So thank you for our audiovisual folks. I'd also like to thank the AMSA team for their hard work in making this event happen today. This was like hours and hours of planning, and it's been, again, really amazing. So thanks for bringing us all together here. Lynn, Katie, Bahar, Lucy, Patricia, and Sabrina. And I just want to give everybody a reminder, in your folders, when you registered, there's a yellow piece of paper, there's an evaluation form in there. Please fill that out and drop it off on your way back. It's super important to have completed evaluations, to know that these kind of events are useful. How do we put on events in the future that are equally as useful, and how do we reach folks that we haven't reached today? For those of you online, please complete the online evaluation form and send it to AMSA by Monday, March the 14th at 5 p.m. Again, encourage all of you to fill out that evaluation form. It's really, really important. Thank you all for coming today. It was a rainy Monday morning, but I think this discussion has been incredibly informative, really interesting, and I hope it gives you some food for thought, and that you continue these discourses both in your own organizations, with your friends, and across the sectors. Thank you so much for our speakers, Naomi, Maylin, and Anne.
Thank you.
Thanks.
Thank you. Thank you. Thanks. Thanks, Kayla. I'm assuming we can go now.
Oh, I forgot to mention, I'm sorry, I forgot to mention, I don't know if we're still online or not, that if anybody who had a question that didn't get to ask a question, please send it into AMSA. They will try to respond and send it out to the group. Oh, so sorry. Naomi, we need to get together and talk. I know.